Welcome to this episode of Substantial Matters, Life and Science of Parkinson's. I'm your host, Dan Keller. At the Parkinson's Foundation, we want all people with Parkinson's and their families to get the care and support they need. Better care starts with better research and leads to better lives. In this podcast series, we highlight the fruits of that research, the treatments and techniques that can help you live a better life now, as well as research that can bring a better tomorrow. According to the Cleveland Clinic, it's estimated that up to 30% of Americans may experience a neuropathy during their lives. These feelings of numbness, tingling, pain, or other abnormal sensations often result from damage or dysfunction of sensory nerves in the periphery. These are the nerves that bring sensations to the brain and spinal cord, which form the central nervous system. In this episode, nurse practitioner Ellen Walter of the Cleveland Clinic gives a brief overview of the various kinds of neuropathies and then focuses on peripheral neuropathies. She also goes into some detail about the importance of identifying the specific causes of neuropathies, since some can be treated.
I think this is actually kind of a tough topic to cover. And by tough, I mean it's not necessarily straightforward, but I think that's why people are often interested in hearing about it and learning a little bit about neuropathy. But basically, short and simple, neuropathy is damage to the nerves. And today, as we talk, I'm mostly going to speak about peripheral neuropathy, so damage to the peripheral nerves. So this is the part of our nervous system that carries messages to and from the brain and the spinal cord. So there are different types of neuropathy or nerve damage, but again, we'll mostly focus on peripheral. But for example, carpal tunnel syndrome is a type of what is called a focal neuropathy. Another example is an autonomic neuropathy, so damage to the nerves that control the automatic functions in our body that we just don't think about, such as heart rate, blood pressure, digestion. But again, I think it's a little bit complicated, so staying a little bit more focused on the peripheral neuropathy will be our goal today.
And those peripheral neuropathies are mostly sensory, or are there motor problems also?
There can be both. So though I only mentioned a few of the types of neuropathy earlier, there are so many different types of neuropathy. So it really depends on what type of nerves are affected. But basically, just to keep it simple, lumping those together. So someone might feel pain, they might have numbness or tingling that, maybe starts at their feet, works their way up. Someone may be overly sensitive to touch, have muscle weakness, could have loss of coordination, and then some might feel like they have socks or gloves when they're not really wearing any.
Are people with Parkinson's more likely to get neuropathy? And among those people, this population, how common is it?
I think the answer to this question seems to be controversial. I know that when I first started learning about it and people would ask me that question and I would ask different movement disorder specialists, I would always get different answers. But I think when you review the literature, there does seem to be a higher incidence of neuropathy in people with Parkinson's as compared to those without. And approximately 30% of the people who have Parkinson's will develop a neuropathy. So even though as people age, they do have a greater risk for having neuropathy, and certainly with more problems they develop, such as diabetes and things like that, aging alone really does not explain the difference in why people with Parkinson's are likely to get neuropathy.
Besides it being uncomfortable or painful, can it be dangerous?
It can be dangerous if there's an underlying cause that is missed. That might be the reason why somebody is having the neuropathy. So maybe if somebody has cancer, sometimes peripheral neuropathy can be a sign of a cancer, or maybe they have diabetes and it's not being well treated. So if, somebody has, like bone pain, weakness, frequent infections, or other new symptoms occurring at the same time as they're developing the peripheral neuropathy, then that may be a red flag that there is something else going on. So really, I would say that regardless of what the cause is, early diagnosis and treatment is important to help control the symptoms, hopefully prevent further damage. And a type of neurologist called a neuromuscular specialist can actually be seen to verify that somebody truly has a neuropathy and then better help them determine the severity and then the cause, such as one of these that, I mentioned. And especially if it's related to a cancer, you want to make sure that that gets identified and taken care of right away.
If someone, say, has numbness, a peripheral neuropathy affecting their feet, I would think maybe they don't sense the ground very well or things like that. Can this lead to falls?
Absolutely. And that's one of the reasons, and we talked about a few other reasons, like with the cancer, that you want to make sure it's identified. But that is absolutely another reason. People who have Parkinson's disease and then have the neuropathy on top of that, they are at higher risk for having falls as compared to somebody who doesn't have the neuropathy. And I think it can, in some people can be a problem with driving as well, if they can't, feel the gas pedals. And so I think there's a couple dangers that can be a result of the peripheral neuropathy.
What would put a person with Parkinson's more at risk for neuropathy? I mean, you've got their underlying disease, you've got drugs, you've got aging. How do these things all work into it?
So there is a link to the Parkinson's medication levodopa, and most people with Parkinson's end up on levodopa sometime throughout their time with Parkinson's disease. It is the gold standard, and approximately 1/3 of those who take levodopa develop a peripheral neuropathy. I'm referring to the oral medication. But then even more striking is that those who use duopa, which is an intestinal gel form of the levodopa, over 40% will develop a neuropathy, and that tends to be a more acute onset, whereas those who are taking the pill form of levodopa, it's more slowly progressive. And so, then the question is, does this mean we should not use them because they're linked with peripheral neuropathy? And of course not. As I mentioned, levodopa is the gold standard, but I think monitoring of labs that are associated with the neuropathy, such as a B12 deficiency, would be important. And then if you look at the non-medication side, there have been studies of people with Parkinson's who are newly diagnosed, not yet on medication, when compared to people without Parkinson's, they too have a higher incidence of neuropathy. And so one of the articles I had read, I believe it was published towards the end of 2020, they looked at 105 individuals with Parkinson's, and almost a quarter of them were found to have a neuropathy before even starting medication. And again, this tells us that it's not always the medication that is causing the neuropathy, but it's really complicated, and we're not sure exactly why this happens. But what we do know about this group of people with Parkinson's who had the neuropathy as compared to those who didn't and who were not on levodopa yet, they did have some abnormalities in their blood work. And other studies have also found similar abnormalities and also deficiencies in some of the B vitamins, such as B12, B6, and B9, which is folic acid.
Some people have some tingling in their feet at night and goes away. It's transient. Would this be considered neuropathy?
It's hard to know for sure. There is a chance this is not neuropathy, but rather restless leg syndrome, or RLS for short. Many people with Parkinson's have restless leg syndrome, and this is basically when people get an uncomfortable sensation in their legs that then causes them an urge to move. And so they either kick their legs around or they get up, they walk around to make it go away. Because this sensation feels different for different people, sometimes people will describe it as a bug crawling feeling, or sometimes they'll describe it as tingling, or, they just describe it in different ways. So it might feel similar to what a person who has neuropathy may also feel. And then another thing that makes it complicated is neuropathy pain can also be worse at night, which is usually the case with restless leg syndrome. And then to complicate matters more, there can be people who have both. They have the restless leg syndrome and they have the neuropathy. And then I think too, sometimes what people say they are feeling is sometimes the wrong thing. And I think that then is on us as the healthcare provider to take a good history. Because I'll be honest, I've been fooled by patients using wrong terminology. They come in and they say, oh, this has really been bothering me. My restless leg syndrome has really been bothering me. And you work on treating it, only to find out later on that it wasn't actually restless leg syndrome. It's what they thought they had because it sounded like the other person that they know who has restless leg syndrome, when in fact theirs might be neuropathy. And so again, I think it's on us as a healthcare providers to make sure we're doing a good history, and then if there is suspicion of a neuropathy, having them get that looked into.
How do people know when to see a healthcare provider? Are there red flags or things to be particularly concerned about?
Well, I think they should see a healthcare provider if they have any changes that they feel like might be a sign of neuropathy, such as the numbness and tingling or pain. I guess I would again caution people not to actually use the term neuropathy until they're actually diagnosed with it. So, really to describe what it is they're actually feeling rather than what they think they have, because I think that will help. And then if we do think they have a neuropathy, and whether that be their primary care provider, whether that be their movement disorder specialist, then again, we can send them to the neuromuscular specialist that we spoke about earlier. And then the red flags that something more is going on would be the things that I mentioned, like with cancer, like maybe bone pain, or maybe if they're developing weakness, maybe that means that there's a nerve that's, trapped somewhere that's causing the numbness and tingling, but also because of how it's trapped, it's causing them to not be able to use their hand as well, or maybe some weakness in, one of their legs. And then, frequent infections and other new symptoms would also be the red flags.
How big a workup does a person get just describing a symptom? Is there some algorithm or decision tree or map for this?
I think it really depends on the situation. So a lot of times if somebody has numbness and tingling and maybe some pain, so say it's in their arm or, even their leg, a lot of times when somebody has, a compressed nerve or something, it could be temporary. So a lot of these kind of go away on their own. And so sometimes, you might have somebody monitor it, but if they have weakness, I wouldn't wait and monitor it. I would definitely send them to a neuromuscular specialist to evaluate, or if we had an idea of what it was, to the appropriate person, maybe spine medicine if we thought something was coming from the back, something like that. But if somebody just, yesterday I started feeling some numbness and tingling in my right hand, or, it's been going on for a week or something like that, you might have them monitor it a little bit. And then if it continues and they end up seeing a neuromuscular specialist, I certainly can't speak for everything they do, but a lot of times what they'll do is a EMG and nerve conduction study where they look at how the nerves are functioning and they're able to tell, is this a neuropathy? Is something going on in the neck? Is something going on in the back? Does it seem like to be the type of neuropathy that is associated with, diabetes or something like that? And then if they identify that it is a neuropathy, then a lot of times they'll do blood work, obviously, a history, but then they'll also do blood work to identify and look for different causes. So they might look for some of the deficiencies we were talking about with the B vitamins. They'll look for maybe if they have diabetes, what their blood sugar control has been like. There can be other causes of neuropathy that maybe they'll look into, or they'll know that, okay, this is probably the cause of it, say the rheumatoid arthritis or kidney diseases. There's a plethora of list of things that could contribute. And then I think with Parkinson's, my big thing with treating people with Parkinson's is just because you have Parkinson's doesn't mean everything is Parkinson's. And so I wouldn't look at somebody if they came in and they seem to have a neuropathy. I wouldn't say, oh, well, you're on levodopa. It must be your levodopa. I don't think we should blame Parkinson's until it's time to blame Parkinson's. And so I think the neuromuscular specialist would do just that. They would look for other potential causes and, and see what might be contributing.
So it sounds like what can be done about this really depends on what's causing it, whether it's metabolic or a deficiency, as you said, with vitamins, or an impingement syndrome or the levodopa. So I guess you really have to get at the cause before you can get at a treatment.
Absolutely. And that would actually be the first step. You got it. So any underlying causes should be identified. A deficiency needs to be ruled out or identified as the cause and treated. Controlling blood sugar, say as in the person with diabetes, or even in the, people who might be what they consider, pre-diabetic, to make sure that sugar is well controlled so as not to worsen the neuropathy, even if it is caused by something else. Maybe that's not the initial cause, but you certainly don't want to make it worse by adding to it. Stop smoking if somebody smokes, because it constricts the blood vessels that supply the nutrients to the area to keep the area healthy. Exercising, for the same reason, to increase the circulation, delivering the oxygen, the nutrients to the area. And then, a lot of the treatment for like say a peripheral neuropathy is going to be aimed at controlling the pain. So taking different medications such as like gabapentin or Lyrica or Cymbalta. Those are some well-known treatments for it that those names might be familiar to people. Sometimes people will use a topical cream such as lidocaine or capsaicin. Then if there's other types of neuropathy that, as you mentioned, are due to, say, an entrapment of a nerve or something like that, maybe they need surgery for carpal tunnel syndrome or what's called an ulnar neuropathy. Maybe, it's kind of similar to carpal tunnel syndrome in a sense, just in another part of the body. So a lot of it is going to be determined. And then some of the autonomic type of things, that can affect maybe digestion, or there's a type of, nerve damage for urination that they might use like a peripheral nerve stimulator. So there really are different types of treatments that are going to be determined, you said, by what is actually causing it or thought to be causing it.
So if I hear you right, it sounds like those things that people can do for themselves if they have neuropathy also may be good things to do so as not to develop it. Stop smoking, don't get overweight, things like that.
Exactly. So limiting exposure to toxins or, limiting your alcohol intake, since alcoholism can cause neuropathy, controlling the blood sugar, exercise like we mentioned, taking steps. One type of nerve damage that occurs is in people who get shingles. And this can be a very, very painful type of nerve damage. So maybe getting the vaccination to prevent shingles. When we look at the neuropathies like carpal tunnel syndrome, avoiding those repetitive movements that may cause a neuropathy like carpal tunnel syndrome. And that's not always possible, right? And, somebody has a job where they're typing, 10 hours a day. That's something that's hard to avoid, but maybe they can do some typing and then maybe they can use some type of device where they can dictate some, just trying to think of different ways to avoid some of those repetitive movements or at least break it up. Sometimes people will wear, a brace at night if they sleep a certain way. That can cause carpal tunnel. Sleeping with this type of hand brace can help open it up and prevent that from happening. A good diet to prevent vitamin deficiencies, and that's a little bit tough. With vitamin B12, a lot of people get enough in their diet, but then it's not always absorbed. So sometimes people, instead of taking a B12 supplement, they might need an injection to help with the absorption. And then I would say just having open communication with your providers about monitoring for deficiencies, especially if someone is on medications that may cause the deficiencies.
Have we missed anything important, or is there anything interesting to add?
I think the key points I would say here is just don't blame everything on Parkinson's. As I mentioned, don't be afraid to ask your provider, if you think that you need to be checked, whether it be your primary care provider or the person who treats your Parkinson's. I try very hard to think about checking for B12 deficiencies and other things, but sometimes you go into your office visit and you have a plan in your head of how the visit's going to go, and then they come in and they have some other concerns and your visit goes a different direction. And so maybe this time we didn't check, but people definitely should not be afraid to ask, because again, there can be a B12 deficiency, there can be other deficiencies, but the B12 one I think is a big one for us because of the levodopa. And then there are other medications, which I would say out of a lot of the medications I'm aware of that can contribute to a B12 deficiency. In addition to levodopa, there is metformin that can cause a B12 deficiency. And a lot of our patients who have diabetes are on metformin. So then you have a couple different things that are working against you in regards to the possibility for a deficiency.
Very good. A lot of information. I'm sure our listeners will appreciate it. Thank you. More about today's topic, search on neuropathy on our website at parkinson.org. There you can find an article that discusses neuropathy in people with PD, as well as fatigue and gastrointestinal issues. As Ellen mentioned, not all neuropathies accompanying PD are directly related to the disease, and the article lists a wide range of other possible causes, including medication side effects and normal aging. It may be a good idea to look over the list of medications in the article to see if you are taking any of them. Other medications may be used to alleviate neuropathic pain, but they do not stop the nerve damage itself. It's also worth noting that deep brain stimulation can cause a tingling sensation that may be mistaken for neuropathy, and often an adjustment of the device can eliminate this side effect. If you search our website on Ellen Walter, you can find an even more in-depth discussion of neuropathy in the expert briefing that she and clinical pharmacist Stephen Swank presented. You can also learn more by searching for our Pain in Parkinson's fact sheet by visiting parkinson.org/library. And of course, our helpline information specialists can provide more resources. As always, they're available to answer questions in English or Spanish about today's topic or anything else having to do with Parkinson's. You can reach them at 1-800-4PD-INFO. News and updates about future events and resources are available by joining our email list at the bottom of our website's homepage. If you want to leave feedback on this podcast or any other subject, you can do it at parkinson.org/feedback. If you enjoyed this podcast, be sure to subscribe and rate and review the series on Apple Podcasts or wherever you get your podcasts. At the Parkinson's Foundation, our mission is to help every person diagnosed with Parkinson's live the best possible life today. To that end, we'll be bringing you a new episode in this podcast series every other week. Till next time, for more information and resources, visit parkinson.org or call our toll-free helpline at 1-800-4PD-INFO. That's 1-800-473-4636. Thank you for listening.